Hey everyone, my name is Mackenzie Whitlock, and today I'd like to present a very interesting case about an anti-Wra fatal hemolytic transfusion reaction. The patient in this case study was a 66-year-old Caucasian female with a history of osteoarthritis, diabetes mellitus, and a right hip girdle stone procedure. In the last 3 years, she had sustained transfusion of 13 packed red blood cell units in conjunction with her hip surgeries. At presentation to the hospital, she was experiencing hip pain. She had a low hemoglobin of 8.5 grams per deciliter, and she was thought to have intra-articular bleeding. Since the patient's hemoglobin was at 8.5 and was very low, the staff decided that they would order pre-transfusion testing on this patient. Her antibody screen was negative. She was not found in the transfusion register for irregular antibodies and cross-match problems in the Netherlands. And an immediate spin cross-match was performed with 2 ABO identical units and were found to be compatible at immediate spin. And despite those units being compatible, after administration of the first unit, the patient began to experience chills, neck pain, fever, vomiting, and abdominal pain. And at this point, the medical team thought that these symptoms were nonspecific and that they were too similar to her pre-existing symptoms, and so that they did not think that this was a very severe reaction, and they wrote it off as a very mild transfusion reaction. And due to that, they decided to go ahead and follow through with the transfusion of the second unit. However, after the second unit had been administered, the patient's temperature dropped. She also experienced a blood pressure drop, and she was found to have very serious renal and hepatic irregularities. Her hematology results, as we have briefly discussed, her hemoglobin at presentation was 8.5, and after 1 day of being admitted, it had fallen to 8, likely due to her intra-articular bleeding. After administration of the first unit, her hemoglobin did increase, but unfortunately, a little time after that, it plummeted down to 7.6. Her blood smear analysis also showed spherocytes present, but no CBC was ordered on the patient. Her chemistry results showed increased bilirubin. At admission, it was normal, and it had gone up significantly after 10 and 13 hours after administration of the first unit. Her liver enzymes were also normal at admission, but skyrocketed after administration of the first unit, as well as her LD. It was normal, on the high end of normal at admission, and it also went up grossly. Her creatinine was normal at presentation, but also increased after administration of the first unit, as we mentioned her renal irregularities. Her haptoglobin also was normal at admission, but fell very significantly after the first unit was administered. And her blood gas results were also significant and showed she had a very acidic pH, and we will discuss that later. Her blood bank results, as we have also discussed, she had a negative antibody screen at admission, and it was also negative after the transfusion. When tested after the transfusion. Her immediate spin cross-match with those 2 ABO identical units, as we mentioned, were compatible. However, when an IAT cross-match all the way up to anti-human globulin was performed with a pre-transfusion sample and the first unit, it was found to be incompatible with a 3+ reaction. The antibody ID panel also showed that it was positive with only the right A positive cell. It was a 3+ reaction, and she also had a negative autocontrol with that antibody ID. Her DAT was negative at admission, but it was a weak positive following the transfusion. And an LUIT was taken, and it was tested with the with the panel cells, including the ROT-A positive cell, and it was negative for all of those. So at this point, the team could not, without a doubt, say that the ROT-A, with the anti-ROT-A antibody, is what caused this hemolytic reaction, because it also could have been another low-frequency antigen that maybe was present on the cell, but it wasn't listed as present. As far as hemolysis, I would like to discuss some of the pathophysiology and the corroboration with the lab results. With anti-ROT-A, the way that particular antibody works, you do not have to be sensitized. You don't have to be introduced to that antigen in order to form a response. So it's possible that this patient this is her first interaction with the ROT-A antigen, and she could have formed a response that way. Or it also could have been a memory response, since we do know that this patient has an extensive transfusion history. She's been transfused with 13 units of packed red cells within the last 3 years. So it's also possible that she could have been exposed to this antigen before, although it is very low frequency. And so that's why it is not included on screening cells, because it's very unlikely that the patient will encounter that antigen. But a possible mechanism for the hemolysis in this case is the activation of the complement cascade, as the anti-ROT-A antibodies can be either IgM or IgG, which can both activate the complement cascade, although IgM is more efficient. And the reason that I think this patient has hemolysis is because her hemoglobin did increase after administration of the first unit, but then there was a sharp decrease. And at this point, I think that there was a lot of free hemoglobin in her blood, and that's supported by the fact that she developed gross hyperbilirubinemia following that. So she was trying to break down all the free hemoglobin, and that produced a lot of bilirubin. We can see from her chemistry results, her bilirubin was normal at 12 when she was admitted, but it went up very significantly to 166 10 hours after transfusion of the first unit. She also had increased lactate dehydrogenase, which is also indicative of hemolysis, and she had decreased haptoglobin, and that is a hallmark sign of hemolysis. So since she had a lot of free hemoglobin, the haptoglobin was binding that up, and once the haptoglobin was exhausted, that's what we're seeing now, because it's almost indetectable. Her haptoglobin is at less than 0.1 grams per liter, and it was normal at admission. So it's very probable that the transfusion was what caused the decrease in haptoglobin due to being bound up by the large amount of free hemoglobin after destruction of the cells with hemolysis. We also discussed that the patient had renal damage, and that is supported by the fact that her creatinine progressively increased following the transfusion. She was normal for creatinine at admission, which it was at 70, but after administration of the first unit, it continued to increase. It was 212 at 10 hours following the first unit and 263 at 13 hours following the first unit. And as we well know, the kidneys are integral in ion balances, and so it's very possible that this could contribute to her abnormal blood gas results that we'll also discuss in a moment. We've also mentioned that the patient was shown to have hepatic damage, liver damage following the transfusion, and that is supported by her liver enzymes being grossly increased. Her ALT experienced a 20 times increase from her admission values, and her AST experienced a 40 times increase from her admission values to post-transfusion. And the liver is also involved in acid-base balance, so it could also have contributed to her blood gas results. So now I'd like to discuss those blood gas results. Since we know that she has a low pH, it started out at 7.17 at 10 hours following transfusion of the first unit. There was no blood gas taken at admission. And within 13 hours after transfusion of the first unit, it had fallen all the way to 6.99. So with a low pH as well as a low PCO2, we know that this is metabolic acidosis rather than respiratory acidosis. And since we also have a low bicarbonate, we know her body is trying to compensate for this acidotic process. And so since she does still have a low pH, we know that it is not completely compensated. And so this is a partially compensated metabolic acidosis. In addition to that, we've discussed that she has kidney damage, she has liver damage, and we will talk about later. She also had respiratory distress, and so we know that she has kidney, liver, and lung damage at the very least. And this leads me to believe that she had some type of organ ischemia. And we will later see her autopsy revealed that she did have kidney and bowel ischemia, and this also supported a shock diagnosis. And the blood pressure drops that she experienced lead me to think this may have been, the organ ischemia may have been associated with disseminated intravascular coagulation, or DIC. Unfortunately, no coagulation tests were assessed for the patient, and there was no CBC performed, so we cannot evaluate her platelets or anything. In conclusion, the patient was diagnosed with an acute hemolytic transfusion reaction due to Anti-Wra. This was because she had a positive DAT post-transfusion. There was an incompatible cross-match with the first unit at AHG using the pre-transfusion sample after the transfusion. She also had a positive reaction on the antibody panel with only the Wra positive cell. And she also, her LUIT from the DAT was negative with the Wra panel cell, which they thought was due to using PEG instead of LIS as the potentiator. And so they think if they had used other elution methods, used different potentiators, this would have been positive. However, there is no record of further testing to rule out other antibodies to low-frequency antigens. The autopsy and blood cultures also ruled out contribution of infection to the etiology of her disease and her passing. The patient actually died from an adult respiratory distress syndrome, which indicates she had some lung issues, as we discussed earlier, as well as multi-organ failure, which we also discussed. Despite administration of saline following the second transfusion, despite being administered hydrocortisone, and despite transfer to the intensive care unit. Some pertinent questions that have to be answered in order to fully understand this case and implications of it for future testing is, why was the incompatibility with the first unit missed despite following pre-transfusion protocol? So as far as pre-transfusion testing, the lab did everything that they should have done, everything that's required. However, because only an immediate spin crossmatch was performed, the Wra antigen was not, the anti-Wra antibody could not be picked up on. But as we know, since they, after transfusion, took this crossmatch to AHG, it was incompatible. So had they done an IAT crossmatch instead of just an immediate spin, they would have caught this unexpected antibody. In addition, the ROT-A antigen was not represented on the screening cells that were used because it is such a low frequency antigen, and so most of the red cells that are administered in the general population are not going to be ROT-A positive. What is the significance of the patient's positive DAT? So the DAT was positive because the patient's red blood cells were coated with antibodies within the patient's body. So we know that the patient had antibodies that reacted with the red blood cells that she was transfused with. And so that indicates that the blood that she was administered was not compatible for her, because she would have had antigen negative blood in order for it to be compatible. And finally, and this may be the most important question, is should policy reform be implemented to mitigate severe and fatal acute hemolytic transfusion reactions involving antibodies to low frequency antigens such as anti-Wra? And if so, what options should be considered? The first option, and possibly the most difficult option to actually carry out, would be to create more extensive antibody screens to include those more low frequency antigens like ROT-A and other antigens in the Diego group, because there are a few more clinically significant ones as well. As there is an unexhaustive list of low frequency antigens that could be included on antibody screens. However, if we were to include these low frequency antigens, there are a lot of obstacles to that. First of all, they're low frequency. So not many donors in the population are going to actually have these antigens on their red cell surface. So you would have to do a lot of searching in order to find those donors, and at that, in order to have an ample amount in order to continue to produce those cells. In addition to that, it's going to be a lot more expensive in order to make those more extensive antibody screens, and it's also going to be it's going to slow down your pre-transfusion testing in order to have to use all of those cells for the screens. And then it's also going to be more expensive. The next option, which is a little bit more doable, is to perform routine DATs post-transfusion for these patients. So in this patient's case, she did have symptoms. She had fever, she had chills, she had neck pain, vomiting, abdominal pain. All of those things with her condition, they were pre-existing and they were considered to be non-specific. But had a DAT been performed, the team would have known at that point these symptoms are significant. They do not just indicate a mild transfusion reaction. They would know it was hemolytic, and they could have not administered the second unit, and they could have provided more quality care to this patient and possibly have saved her life. And the next one and the final option, I think, is probably the most doable, and it's probably the safest route as well. So that would be to perform IAT cross matches or go out to AHG for each patient and each unit that's administered to that patient, because not only do you have the immediate spin to know that the ABO type is correct, you would have the AHG, and this would be a second safety on top of doing the antibody screens, because the antibody screens they include the most clinically significant antigens, the ones that are most common, and they may not pick up something like Anti-Wra in the Diego group. But if you perform an AHG cross-match, you're going to pick up on these unexpected antibodies. So that is another safety. And I think that that's probably the best course of action. Even though it would slow down pre-transfusion testing, it would be so much safer. And in this patient's case, performing an IAT cross-match would have saved her life, because she never would have been transfused with that first unit that was antigen positive while she had the Anti-Wra antibody. She never would have been transfused, and she would not have had the hemolytic transfusion reaction. She wouldn't have passed away. So weighing the pros and cons, and what you would be more expensive, because you can't just do we would be abandoning the computer cross match, the immediate spin cross match that are quicker, but it would save lives, I think. And at this time, I'd like to give credit to the references that I used. The case study is this first citation here, and the rest of these sources helped me significantly with interpreting the results. So I hope everyone found this case study to be interesting. I hope it helps you think more about blood bank and just how serious it can be, as well as just everyone learning, because the pre-transfusion testing, everything that the lab did on this was what they should have done and what is standard protocol, but it still wasn't enough to save this patient's life. And so we can always be learning and growing from experiences like this. I hope you enjoyed this case. Thank you.